Let's turn to more on the driver mutations. And we have established a clear benefit, overwhelming benefit with EGFR inhibitors and even TRK with good treatments have commercially available agents. So these are now a standard of care. But at ASCO, we also saw some new results with targets that are not at this point a standard of care. And I'd start with MET. MET exon 14 mutations are seen in about 2, 3, 4% of lung cancers. And we didn't have anything that had been consistently tested or looked that favorable. Crizotinib can be of benefit, but at ASCO 2019, we saw the results with 2 different MET inhibitors, both oral agents, one called tepotinib and one capmatinib, that I would say looked pretty similar, and both in the kind of magnitude that we hope to see for a blow-us-away targeted therapy. These were both agents that had response rates in the 40, 50, 60% range, and some evidence of intracranial activity and good tolerability as well, mostly with peripheral edema, some fluid retention issues maybe, and maybe some nausea, but nothing prohibitive. Charu, what did you think of these data? Was there one of these agents that's a clear front runner to you? And how encouraged are you that one or both of these agents will make MET a target that we are soon going to need to be looking for, because we will hope to have an effective agent available to treat these patients?
Yeah, so I think, Jack, there was a lot of excitement around some of these unusual targets, or rare targets, I should say, MET and RET. And, right now what we have at our disposal is really crizotinib, which we have been using for these MET exon 14 mutations. But the response rates that we are seeing with these newer agents, both tepotinib and capmatinib, are really encouraging. And I think, I'm a strong believer that if you have a targetable mutation, that you should treat with targeted therapy first before treating them with a standard chemoimmunotherapy or an immunotherapeutic approach, along with emerging evidence that immunotherapy actually may not be very effective in patients with MET exon 14 mutations. I would like to point out that there is also emerging evidence of sequential TKI use after chemo IO. We've certainly seen this with EGFR inhibitors, but there was also a publication last year in the JTO where they looked at use of crizotinib and increased rates of hepatitis in patients that had received crizotinib after having had either immunotherapy alone or chemoimmunotherapy. So I find that, if you're finding these mutations, we should treat them in first line with a targeted agent and perhaps save chemo IO or chemoimmunotherapy approaches for later. Now, we're not going to have randomized trials. Maybe, I doubt that there'll be a randomized trial of chemoimmunotherapy versus a TKI in these such situations. And I would argue that we probably don't need a trial given the kind of responses and intracranial responses we are seeing with these drugs. So I'm very encouraged. I would think that they are very similar in their activity, and I would love to get one of these drugs available to use outside of a trial.
Ben, what do you think, and particularly about the first line? I mean, with agents that have phase 1 and 2 data that look good, but obviously it won't be anytime soon that we have a phase 3 trial comparing a targeted therapy to chemoimmunotherapy for these folks. Probably never. And I agree that we don't necessarily need that if the response rates are 50% or higher. But given the issues of getting molecular results back, particularly for NGS patterns, if you're looking for now 8 or 10 different markers, that means you're sending off an NGS panel that may take 3 or 4 weeks to get back. Many patients and oncologists are going to be anxious to start something else. How do we reconcile this? What's your thoughts on how to incorporate these newer but uncommon agents and where to sequence them?
Yeah, I think the Charu really nicely stated some of the concerns I have with starting IO on patients where we don't know the mutation and then it returns, and then using these TKIs and the potential toxicity of this sequencing strategy. I want to say that this data really underscores the importance of testing in general, but piggybacking on that, at least in the VISION trial with tepotinib, they used plasma to identify these patients in over half of them. And the response rates in plasma, exon 14 skipping, were similar to those that were in tissue. So, in this, we could go on and on about the importance of testing and not just using tissue and plasma and some of the new data that's out there. But to me, this just reinforces, and Charu knows this better than I do, being a lead author in one of the seminal works for this, the importance of also identifying these mutations in plasma. Interestingly, of the 3 MET exon 14 skipping mutations that I've treated thus far, I have all identified them in plasma and then subsequently confirmed them in tissue thereafterwards. And what Charu was talking about, the sequencing issue of using IO first and then going on to these TKIs. I mean, more and more reasons why to try to get your answers quicker. I'm not saying that the plasma is the end all be all, but certainly we've now got data from one of these drugs that we can identify these mutations in plasma, and it is predictive in the plasma to these drugs. So I think we're still trying to learn, but look, response rates of 50 to 60% for these drugs is just more reason we need to be testing. I can't wait to use these drugs if they get approved. I don't think we need phase 3 trials. We're going up against crizotinib, which only has a response rate of 30%. So just a welcome change, and again, underscores the importance of testing.